So what are we doing at the moment in hospital pharmacy in this context of integrated care? Well, as pharmacists, we are specialists in medicines, we are experts in medicines, and we're expected within the hospital to provide a leadership role around medicines use, which of course we do. But also at the moment our prime focus has been around a safe and effective use of medicines, and now under the banner of medicines optimisation we're obviously looking at patient-focused outcomes as well. But you can't be interested in patient-focused outcomes within the four walls of the hospital. You have to be thinking about it broader than that. And so we have to be thinking about how we support patients before they get to hospital, and also what happens when we transfer them out of hospital and how we do that safely. Colleagues around the country will be familiar with the work that I suspect we're all doing in trying to tackle medicines adherence and also medicines related admission. We know that about 5 to 8% of admissions have got something to do with medicines. Certainly locally we've done a similar audit to see what's happening in our own hospital, and it was about 5% of admissions acutely were because of, or readmissions were because something to do with medicines. We are charged also with an extraordinary resource very often. It's usually about 10% of a trust's turnover is in the expenditure on medicines, and that we have to manage that very carefully, and of which of course we do. We manage that and we manage to minimise costs, but we do that in terms of the whole healthcare economy as well, not just around medicines, whilst at the same time maintaining optimal care for our patients. Also within hospital there is an expectation as a pharmacist that I know my community colleagues. So in January and February we're now working with a large multiple that we've got on site in a contract, so we have interest from the community pharmacy there, and they're supporting us to improve the quality of care for our outpatients. I think many of us are trying to do work around preventing and reducing readmissions. And one of my colleagues in Newcastle has led a piece of work, Dr. Julia Blackburn, called the REACH project. Medicines reconciliation are education of patients. That's very individual patient-focused education, assessment of patient needs, referral to community pharmacy, that's a manual system at the moment, and home visits where that's required, where community pharmacy can't provide the support. And that seems to be unlocking some activity, particularly relationships with community pharmacy. We've had electronic prescribing for adults for all inpatients for the last 4 years, and that's allowed us to do some really quite clever things in the last year or so, particularly around making medicines reconciliation at the point of admission much safer, because we can get the medicines information captured, put into the electronic record, and then through a process whereby the junior doctor, without transcribing, converts that to an electronic prescription rather than handwriting. We're also using the system to identify high-risk patients, and that list of high-risk patients, those patients who we know are at risk of readmission, we then follow up with and can do things with community pharmacy. We are now referring, in fact from the 1st of July we're going to be using an electronic referral mechanism whereby we can refer to community pharmacy for them to undertake medicines use review or the new medicine service. So we're tapping into an already commissioned approach. And that's very interesting and it's very helpful to be able to do that. But actually I think our next steps is we need community pharmacy to be commissioned to do things outside of the new medicine service and the medicines use review. So that if we've got a patient at home, for example, that needs support, rather than myself and my team going out to see the patient, then I think that's a role that community pharmacy should be playing. Thank you.